Thank you for joining us for the OpenPrescribing webinar for Medicines Optimisation teams. My name is Richard Croker. I'm a clinical informatician at the Bennett Institute for Applied Data Science. I've been working on OpenPrescribing since about 2016. I'm also Chief Pharmacist for Primary Care at NHS Devon, so work in a MedSop team like a lot of you guys will be doing as well. So we'll talk about primary care prescribing data. Most of you will know about this, if not all of you. Prescriptions written in a GP practice for medication sent to the pharmacy. The pharmacy processes the script and supplies the med to the patient. At the end of the month, all the pharmacies send off all of their dispensed prescriptions to the BSA, who collate the data, process it, and pay the pharmacies accordingly. But that leaves us with a massive load of data every month on prescriptions, which patient it was for, which GP prescribed it, which pharmacy dispensed it, what drug, how much did it cost, all those sorts of things. That's the data set that we use. So the BSA make a subset of that data available openly online. You can go off and you can download it. It's anonymized, so there's no patient level data for us to be able to see. So that's one of the things about OpenPrescribing. We can't tell who's getting it, we just know somebody's getting it. But it does tell us what GP practices have been prescribing. Data comes out around about 2 months after the end of the month that the supply is related to. So, for example, we're currently running on June's prescribing data, which came out in August, and in the next couple of days, we're expecting July's to turn up. And as soon as it comes out, we will be putting it onto the site. We try to avoid complex terminology where we can, but there are two important definitions. The first one is what an item is. So that's the number of times that something's been prescribed. So you've got 2 items for amlodipine 5 milligram, that will show up as 2. And you also have quantity, which is the total amount supplied. So that will be, for example, 2 prescriptions for 28 amlodipine 5, that will show up as a quantity 56. Sometimes difficult when we're writing measures to marry all those up, particularly where you've got liquid formulations, because the milliliters don't match a dosage form. They tend to be spoonfuls. So we have to work things out and divide them by 5 and those sort of things. So we'll talk a little bit about that maybe in a bit. The data is massive. I went to have a look this afternoon at what June's data looks like. There's 17 million rows of data every month, about 6 gigabyte CSV file. Way too big for you to open into Excel. It'll open the first million, I think, rows, but it won't go much further than that. So in our server, we now have around about 2.6 billion rows of data because we've been collecting this now for some time, which is a really, really useful large resource that we need to do. But we need to do something with that data in order to make it usable. That's where OpenPrescribing comes in. It takes the data files and presents the data in a way that allows us to do benchmarking, further analysis, and measures. OpenPrescribing is freely available for all. It's fully open. There's no login needed. We have about 20,000 unique users per month. The majority of the users are from the NHS. People like yourself, people like MedSop teams, and other users within ICBs, as well as GP practices and pharmacists and GP practices to benchmark prescribing, see how they're doing, and see where there are opportunities for development. And we hope that OpenPrescribing can help identify those areas for improvement and prompt discussion and action. In terms of the data, we focus on GP data. The raw data set does include things like out-of-hour services and urgent care centres and things like that, but it's quite difficult for us to manage in terms of building a measure because they don't have a list size, so we can't weight them by population, and often their prescribing is a bit unusual, so we tend to filter all of those out of hours and other places out. There are various different ways for filtering for populations. We no longer use AstroPUs. I can explain that later if people want me to. But basically, they're not very well kept up to date. Medicine changes, prices change, as we know, and often people use them incorrectly and use them for weighting parts of prescribing, which is not what they were designed for. In the same way, star PUs haven't been updated for about 10 years. We've just removed star PUs for antibiotics from the website for the same reason. So we just use a simple list size, so that we're not providing a false assurance or a false weighting for stuff that's a bit out of date, because adjusting for things is complex and difficult, if not impossible, to get right. So we feel that using the simplest adjustment possible by list size is probably the best way, and that be the trigger for a conversation to understand why there is variance in prescribing. Just give you a little clue as to what the measures look like. This is the back end of one of our measures. I think this is high dose opioids by looks of things. So the code is written by myself and other members of the clinical informatics team. I have Chris Wood on the call with me today. He's another clinical informatician and GP pharmacist. We go through various checks to make sure it's accurate and relevant. We prototype them, we put them into preview mode, and we just make sure that they're right, make sure they don't look wrong. We spend quite a bit of time doing that. But once we've written it, we don't need to do anything more, because the latest data will populate automatically during our import, and then everything gets updated on every measure every month. We have expiry dates, review dates to make sure that everything's correct. But sometimes things happen, things change. So for example, somebody bought out a simvastatin capsule, I think, or an atorvastatin capsule, which we hadn't assumed was ever going to come out, and so that wasn't included in one of our measures. And that's why we're always really pleased to receive emails from users telling us if they think we've got something wrong, because we can go and check and then fix it. So please email us if you ever see anything you're not quite sure about, as I know that many of you do. I can also give a much nerdier talk, possibly not for today, about how we moving towards using the Dictionary of Medicines and Devices, because that's a much more powerful way of manipulating the data or classifying the data to allow us to find solid dosage forms and things like that. But yeah, as I say, I don't think we've got time today, and I'm not sure how many people will be interested. We also need to think really hard, though, about how we display the data and what our analytic choices are. So when we're prototyping a measure and decide how we're going to show it, we need to think about various things. We've got some blogs on this. The first one is that we tend to have a consistent way of describing our data, so that although these words are not 100% accurate, tends to be that if you are low in the indicator, you're considered to be good or better, although those words have connotations that we're trying to get away from. And if you're high in the data, then you're more of an outlier, where it's probably more worthy of investigation. So that means that sometimes we word things in a way that make things are different to other groups. So sources like eCompact or Prescript or PHE fingertips, whoever it might well be, may show data in a different way. Most people use the same data set, so actually in terms of analytic choices, sometimes that's the key difference. So a big one for me is how we measure data. We use data on a monthly basis. We don't use rolling data for any of our measures. And that's a decision we made just so that you can show variation more quickly. This is a chart showing so broad spectrum antibiotics, basically as a percentage of total commonly used antibiotics. And you can see the real differences between using 1 month data and using a rolling 12-month period here in particular. So back in December 22, there was the concerns about eye gas outbreaks. And I think we all saw a huge amount of increase in Pen-V, amoxicillin, etc., etc. Consequently, this has gone down as a result. So that's not about fewer prescriptions for broad spectrum, it's about more prescriptions for other antibiotics. And consequently, you can really see that change for 1 month in that period. But if you take the 12-month rolling data, you can see that there's a slight decrease back possibly in December, and it sort of stays in the data for the next 12 months. So that's an analytical choice we make. I'm not saying that other analytical choices are wrong. It's just that's the one that we have chosen at OpenPrescribing to make in terms of that visualization. Okay. Hopefully you should all be able to see that. That is OpenPrescribing. A couple of interesting things for today. Firstly, we have a new news page, which we are populating, which has our latest blogs. And so what we're going to be doing there is when we make changes to any measures or retire measures, which we've just done yesterday, that's not up yet as a news item, we'll be letting you as our users know. So that popped up on Monday afternoon. So we have, I believe, a willing volunteer. Let me just have a look because somebody has messaged me as to who it is. So Shropshire, Telford and Wrekin Integrated Care Board. So let's have a look at them. Okay. So here we are. This is the dashboards, and we do dashboards at every single level of the NHS for GP practices, primary care networks, sub-ICB locations. So that is old CCG level where most of the data still comes in from the BSA, integrated care boards, regional teams. We're doing some work on hospitals at the moment. We're hoping to release some OpenPrescribing hospital data soon. We're doing a lot of work on that. And then we have an All England database as well. So let's start with our friends at Shropshire, Telford and Wrekin ICB. And here we go. So this is our main landing page for an ICB. There are a couple of things that we don't yet have at ICB level that we have at sub-ICB level, which I will show shortly, but let's start with the ICB. So we have 77 live standard measures at the moment for ICBs and other organisations as well. We also have the 24 low priority measures. Those are things, items that should not be prescribed routinely in primary care, which we can look at in a minute. We have price concessions, which we'll come on to, quite important at the moment, and lots of other bits and pieces as well. So let's take a look at the prescribing measures. So we can see that for this ICB, the set of measures here, which are ranked by areas for possible improvement, and we can click that in terms of you can sort by that or sort by savings. We can see that the top ones here are what we got: high dose opioids per 1,000 patients, and then there's some other interesting ones there as well. So if we take a look at the high dose opioids by 1,000 patients, this one looks at any prescriptions for an oral morphine equivalence of 120 milligrams or more per day per 1,000 patients, and it would seem that this is a high ICB that has relatively high prescribing of those. So if we just have a look at this, this is the graphs that we tend to show. The red line is the organisation that you're looking at, in this case the ICB. The thicker dashed line is the median against its peers. So this is ICB, so there are 42 in that peerage, or 41, not including that one. And then the less dense dotted lines are the deciles for each of those organizations as well. And so we can see that in this case, if you hover over it, will tell you in June there were 735 items for high dose opioids against just over 500,000 patients, and you can see here that they're in the 98th percentile, so relatively high. There may be good reasons for that. These are measures, not indicators, so this is about asking the right question, not necessarily providing the right answer. In the why it matters, we provide the information as to where we get the measures from, why we do it, and often what you can do to improve it. Okay, you can also have a look here. So I'll click on here. This will break it down into sub-ICBs. Now, in this ICB, there is only one former CCG, and that will then take you through to that, as take you through to all of those as well. So let me just search for opioids. I won't be able to find it for now. Let me pull that up. So there is also the ability to find by categories. We have most major therapeutic areas available as categories, and we have actually got one for opioids. So this is the same measure at the sub-ICB level, and that then allows you to split into individual practices. And that then shows you, that's interesting, that then shows you each individual practice and their breakdown, in this case, number of items per lists. Oh, I've gone into the wrong one. Let's go back a minute. High dose per patients, there you go. So we can see here there's one practice that has relatively high prescribing, a few that have relatively high prescribing, getting further and further away from the median there. What you can then do at any level that you're looking at this data, you can then break the score down into individual preparations, so you can look at what is causing that problem within within that particular measure. So in this case, they seem to have this practice here, seem to have quite a bit of Zomorph 60 prescribed and some fentanyl 50 and some fentanyl 100s as well there. So that gives you an idea if you're wanting to look at a practice or a PCN or at a sub-ICB level of the prescribing that you need to be looking at. Okay, let's go back here to the ICB. You can also have a look. Sorry, you can also download the data. Some people like to take away the data and download it and manipulate it for their own purposes. You can, all of our measures have the ability to download the data simply by clicking on the download data button, and that will then give you that as well. You can also send this off to the Analyse page. So I'll talk a little bit about that later, but this then shows you all of the things that are in the measure that you may want to look at, and you can look at various things. For example, you can look at a PCN within this particular sub-ICB, and that will give you how many prescriptions per 1,000 people are being prescribed in June 24 over the PCNs. And in fact, if you didn't want to look at them, if you want to look at all PCNs across the country, a lot of data here, so it might take a couple of seconds. It will show you every PCN in the country. As I say, while this is loading, there we are. So this is about explaining how you can use this data to prompt a conversation, identify possible unwarranted variation with practice. We're not saying that because that one practice that we looked at earlier is high, that it's necessarily bad. Okay. In terms of this, you can see this in terms of all PCNs in the country. Let's actually just go back to Shropshire a minute so we can. So it doesn't take quite so much screen space. So there's like whatever they are, 10-ish PCNs across Shropshire. You can also see how they compare in terms of items per 1,000 over time, and you can see that this PCN seems to have done quite a bit of work on reducing it. And you can also produce a map as well. That's at PCN level. They're a bit jaggedy because we don't really have proper maps for PCNs, but that gives you an idea. You can also, if you wanted to, look, for example, at all ICBs, and that will also then give you the map to see how ICBs are doing across the country. There, blue would be good, red would be possible area for improvement. Okay, so it's not all about bad. So let's go back to the start. There's also plenty of things on that you can use to celebrate success with your practices and your other users as well. So we can see here that they don't prescribe any gluten-free drugs. That's great. They don't do 7-day prescribing. That's really good too. Lots of different things here. They've obviously done a load of work in the ICB around reducing the carbon footprint of salbutamol inhalers. So there are lots and lots of measures, 77 altogether, that you can do. And as I say, you can find them by the categories there if you want to do so. Okay, we also, as I say, have the 24 low priority measures. So these are the 24 things that should not be prescribed routinely in primary care, and they are once again sorted as a potential for improvement. I don't plan to talk any more about that, but they are a useful guide, particularly in the Meds National Opportunities at the moment. And we found it quite useful in my ICB to look at areas that we can improve on there. Okay. The other thing you can do within this, and I think Hilary will share a link in a minute, is signing up for alerts or updates. And I think that there's one message I'll ask you to take away today is, if you sign up to our alerts and updates, you find out what we're doing all the time. You get bespoke alerts and updates for whatever organization you want to sign up to, whether it be at practice level, PCN level, sub-ICB level, ICB level, whatever you want to do. I have encouraged the team in Devon to sign up for practice level alerts for the practices that they look after, and obviously we sign up to the ICB ones. They come through every month as soon as the data is uploaded, and they give you a good idea as to where to find possible areas to improve prescribing. Okay, big issue that we all have at the moment, I certainly in my ICB we do, is in terms of price concessions. So we provide for every organization, again, practice PCN, etc., we provide a price concessions dashboards. Now, latest price concessions, the first ones for September came out this morning. I think 5 minutes after we had notification from Community Pharmacy England that they were out, we have pushed the price concessions dashboard update out. What that does is show you historically what the costs have been over the last 5 years. We can see a big peak there once again in December 22, down to antibiotics again, and a big increase in the last couple of months, mainly due to apixaban. So this then gives you where your costs mainly are. It gives you what you would normally pay for it and what your organization is paying extra each month for this. The way that we do it is that we look at the latest month prescribing data that we have, and we send that out as an estimate, because we can't obviously know how many prescriptions have actually taken place in September. 2 reasons. Firstly, it hasn't finished yet, and secondly, we don't get the data till probably mid-November. So you can see on the graph that it's showing as red or orangey red for July and August. That's because we've projected the cost. And then as soon as we get the prescribing data that relates to the month the price concessions are in, we then revise our projections to make it an estimated cost. We've done some validation on this recently, and these numbers are really close to the data that comes out of the BSA. We think that probably in terms of our forecasting, there's about annually a 2% variation, which is pretty good, and helps us understand where the impacts are on price concessions. You can then go back and look. So obviously we've only got September's come out. No apixaban on there yet. So we're still waiting for that one. But if we want to go back and look at August, if it's going to let me there, we can then go back in time and look at the latest full month as well, which is how this would have been showing up until about 11 o'clock this morning. So we can see here projected cost for August. No surprise to see that the big change is in apixaban. So it's going to cost, who's this? Shropshire, isn't it? It's costing them in August about an extra £110,000. We find this tool really useful to share with finance teams. The other key bit that we have is you can sign up. I can't see it there. It's probably because it's not that you can sign up for the alerts as well. And Hilary will share details on how to sign up for the alert. And what we've done in my ICB is encourage finance teams to sign up directly, because they used to ask us quite a bit of the time, how much did price concessions cost? And by sharing this, they get that information straight away. And it's just occurred to me why I can't show you the price concessions, because it's not available at an ICB level for an alert. It's only available at sub-ICB level. We are still working on the ICB level alert. So pop your email address into the sub-ICB level box, and that will automatically drop basically this information, the graph, and the additional cost for each drug of price concessions every time one comes out within a few minutes, and hopefully that's useful. And so I would really strongly encourage you all to sign up to that. Okay, one other area we have, which is only still at ICB level at the moment, is our price per unit tool. So this demonstrates the theoretical maximum of savings that organizations could save if they change from more expensive to cheaper preparations and affect the same thing, whether that be brand to generic, generic to brand, capsule to tablet, and vice versa, those sorts of things. There's clearly a massive caveat on that, and we don't suspect that all of this can be saved, but there are sometimes some opportunities for that to be found. I'm just looking at this graph thinking, oi, so for example, sulfasalazine 500 milligram gastro-resistant tablets, that would be suggesting that the best thing you can possibly do there is to prescribe it as cilazaparin, which would have been great had Pfizer not removed solazepam about 2 weeks ago. So, as I say, big caveats on that. So let's have a look here. Melatonin 2 milligram modified release tablets. You can look here. That will give you a graph of the NHS as the whole in England. Shows that it's mainly prescribed generically in England, and some circadin. But in this ICB, that most of the prescribing is done, so 45,000 tablets is prescribed as circadin, and there is now a more cost-effective generic of which less is being prescribed. So there's a possible opportunity there for reducing some. As I say, it's a big caveat. The way that we do this calculation is we calculate the price per unit of every organization in the country, and then we look at the top of the first decile to see where the lowest 10% of prescribers would be, and then we work out what that price per unit would be, and then calculate the savings in that way. As I say, can't strongly describe the caveats, but there might be some useful things that people can find in there. I suspect if I click on that, for example, there'll be some Eliquis coming through. Yeah, there's a little bit of Eliquis coming through there, which I'm sure that tiny dot there. So yeah, some practices can save quite a bit by moving from Eliquis to Pixpan. Looking at that, I suspect that's probably a dispensing practice. Okay, right. So moving back, just briefly, we have the Ghost branded generics tool, and that was a problem that we had about 4 or 5 years ago, whereby System 1 in particular was showing generics with particular manufacturers' names next to it, and when that hit the BSA, the drug would be reimbursed at the manufacturer's price, not the drug tariff price. The classic example we had was a atorvastatin 40, which was not much more than £1 a box. But if it said atorvastatin 40 brackets Teva, then the BSA were reimbursing at £40 a box. It was due to the way that System 1 was showing the drugs on the system, and it was an issue. We talked about it. We thought it cost about £10 million a year. We wrote a whole blog about it, which is available for you to look at. But System 1 saw that we were writing about it, contacted us, and were very pleased with what we looked at and fixed it. So that's not actually much of an issue compared to what it was. There is a thing here, but it's not showing anything for this particular ICB. It's a few bits, but it'll be rounding errors rather than anything else here, probably due to small pack sizes, so nothing to worry about there. Okay, one of the tools that we've just produced is the Improvement Radar. You can find that under Trends and SICBALL Improvement Radar. So we have measures, we have lots of measures, and we see lots of practices, IPCNs, sub-ICBs doing really well. And we wanted to find a way to identify those, this is sub-ICB location at the moment, doing really well, and allowing other people to find out that they seem to have shown some quality improvement work. And as a result, if you're looking for things to do in your ICB, you can give them a call and say, how did you do that then? So we've built this radar. It's improved every it's updated every 3 months, and it has every one of our measures in it. And you can then see which ICBs have done pieces of work that look really good. For example, let's pick this one here. This is amino acid formula, an extensively hydrolyzed formula. So AAF needed in about 10% of cases of children with cow's milk protein allergy. The ICB average is around about 40%, and it's more expensive. And talking to a dietitian last week, it's not very nice either. So good to not prescribe it if you don't have to. Clearly, Barnsley have done some work there, because they used to be at 50% of their prescribing was AAF, and now it's dropped right down to below 25. So be really good. I don't think there's anybody from Barnsley on the call telling us what you did, but began to easily identify improvement, and so this is where they had to start in the top 20%, sorry, the highest, the worst, or whatever you want to call it, 20% of sub-ICBs in the country, and they had to show continuous improvement to get you down below the median. So that's how we identify this. And there's lots and lots and lots of good examples of good work. I will pick one probably that I like. So the course length for antibiotics for amoxicillin for greater than 5 days, basically. Loads of ICBs have done some really good work on that. Oh, look, Devon, we seem to do really well. I can tell you how we improved that if you want to know. As a result, lots and lots and lots of really good ideas here. That one's particularly impressive, anxiolytics and hypnotics. They've done a lot of work. This is average daily quantity per item. So that's basically the bucket of drug per item. So 7 tablets of Zopiclone 7.5 will be equal to 14 tablets of Zopiclone 3.75. And they've obviously clearly done a lot of work in Calderdale to try and reduce the either high strengths, high quantities, or a mixture of both other anxiolytics and hypnotics. So really good pieces of work, hopefully now really easy to find. So that's available at the top of the page. Okay, lots of other things. So we have dashboards, as I say, for everything. We have it for practices, for PCNs, and the like. We have our drug tariff viewer, which goes now. So why is that not working now? We have our drug tariff viewer. So that shows you the drug tariff in a graphical format. So if we take a completely random example of apixaban, 5 milligram tablets, that will show you graphical terms how much it is and what type of drug it is. This is category C, so it's got a dotty line, and then it became category M, so it's got a thicker line. It will also show you price concessions, so you can see how drug prices have changed. You can do that as well for multiples. Hold down the shift key, and that will let you update. And it can show you both there, so you can see that. And if you wanted to, you can then zoom in just by scrolling that to see what those prices are as well. So that goes back now to 2010. Oh no, 2015, because apixaban didn't exist in 2010. The tool goes back to 2010. So we have the drug tariff here. We also have a dm+d browser, which I find really useful as well. So I'll just pick apixaban there as well. That allows you to look at various things about apixaban in terms of dosing strengths, all the different products. So let's pick Eliquis, for example, and it will then show you the details of the price of Eliquis if it's a brand, and also the drug tariff price if it's a generic. Lots of other things as well. Is it a it's not on here obviously, but is it a controlled drug? Does it have broken bulk? You can find all the different things about those drugs in there. So we find that really useful tool in MyICB, looking up stuff to see how much, for example, branded products cost, and also just what's available, and anything that's coming in new as well. That gets updated on a weekly basis. I didn't talk about the Analyse page very much, but you can do analysis of any drug that you want to do that we're going to wake up and see how you compare or otherwise. Now, the good example that we often use is perisizine, which is an antipsychotic, which, to be honest, I had not heard of until I'd worked at the Bennett Institute. And we can see, is there any variation, for example, in the prescribing of perisizine? Yes, there is. So in Norfolk and Waveney, Sub-ICB, they seem to prescribe a relatively high amount of it. That's a one-off. It might just be one script. It's not one script in this case, but we can also weight it in 2 different ways here. We can either weight it for antipsychotics. There we go. And we can see what proportion of antipsychotics are prescribed as perisizine. So in Norfolk and Waveney, it is 15% of all antibiotics prescribed. All antipsychotics are prescribed as perisizine. You can look at that on a map, and you can see it's quite an outlier. I think it's fair to say. You can also do the same, but weight by list size, and that will give you the same thing. Clearly, in this case, it's high because it's in place that's using it. And you can see also in graphically, and you can see in terms of a time series. What I find this useful for in my ICB job is just finding out how much something's cost us over the last month within the financial year and the last 12 months. So I won't use parasizine because we haven't used any. Let me pick a drug. Do I want to type in tirzepatide? Let me just type atorvastatin. Say 40 milligram tablets. And I work in Devon. It will show us in terms of list size, how much we prescribe compared to others. There's the map. But in terms of how much it costs, if you scroll down in Devon, we can see that we have spent £45,500 on Atorva 40 in June and 141,000 in the financial year, and that much in the last 12 months, and also how many items as well. So I find that quite a useful way of just quickly finding out how much we've spent on something, and it's a useful little tip to have, I think. Okay, what time is it? 20 to 2. So we also have an FAQ, and we would suggest it's worth having a look on this page before you drop us a line. We're always very happy for you to drop us a line, obviously, but the answers you seek might be here, describing all sorts of things about the prescribing data, and we put stuff in when we get asked it into our FAQs as well. So do items claimed on 30 FP34s show up on OpenPrescribing? Short answer, yes, they do. And there's an example on influenza, and you can see how influenza vaccines have been prescribed. And so there's lots and lots of FAQs there that you can use to find out information. If not, please drop us a line. That would be always great to hear from you. We also have, just briefly, national trends, which is sometimes interesting to look at. My favorite on here is always the seasonal variations. So flu clock sodium, having seasonal variation often in the summer for bites, although it also came out January 23 because of antibiotic shortages, or for example, norethisterone. I've got to pick the right one. I think that's possibly the wrong one. Let's have a look. Oh yeah, seasonal variation of prescribing with norethisterone in some holidays as well is always interesting. That's at national level, but if you're looking for how prescribing has changed at a chemical level or at a BNF section level, for example, we're all aware of the increase in prescribing over the last few years of HRT, and you can see there in terms of spend and items the increase that we have seen since July 2019, so probably an increase of 150% in the last few years. Some interesting national data there if you wanted to look at it. Finally, we have a blog which has our news feed. We'll be showing any latest stuff that will tell you anything that we've done recently. We write up various things from how we changed the price concessions calculations, a bit of a nerdy thing, but makes it more accurate. Our newsletters, how to sign up for one of these. We wrote some stuff about prescribing of lidocaine plasters in England and Ireland. There's lots of interesting things there as well. So lots of things to look at on the blog if you were so minded. I'm really aware that is a massive whistle-stop tour. You users are how we work. Some of our best measures have come from emails from you. If you can email us, that would be great. But also, please sign up to our alerts, our newsletter, and our price concessions calculator, because we hopefully will save you time and find it of use. And on that note, thank you very much indeed for coming along today. It's been good to talk to you all, and I'll see you all again sometime. Thank you.